You're listening to the ATS Reading List podcast, brought to you by the American Thoracic Society.
Greetings. I am PJ Gary, and I'm joined today by my co-host, Kristen Richard.
Thanks. I'm excited to be here.
And we're happy to have you. In this episode, we have the pleasure of sitting down with Dr. Tregony Simoneau as we foray into our first reading list episode dedicated to the pediatric population. For our listeners, this is a densely packed episode that will be a bit longer, I suspect, than our usual episodes. We hope you enjoy it. Kristen, take it away.
Thank you. It's my pleasure to introduce Dr. Simoneau. Dr. Simoneau is a pediatric pulmonologist at Boston Children's Hospital. She is an assistant professor of pediatrics at Harvard Medical School and serves as the director of pulmonary ambulatory clinics at Boston Children's Hospital. Her clinical interests are in aerodigestive disorders and severe asthma. Dr. Simoneau graduated from Stanford University Medical School and went on to complete her pediatric residency at Boston Children's Hospital Combined Residency Program, and then pediatric pulmonary fellowship at Boston Children's as well. In her early career, she was an instrumental figure at Connecticut Children's Asthma Center, securing funding for a nationally recognized asthma research project, while following her passion for promoting initiatives focused on eliminating asthma disparities. She became a part of the Boston Children's Hospital Pulmonary Division in 2016 and has since completed impressive work in the Aerodigestive Center and Severe Asthma Program here, with multiple publications focusing on challenges in asthma management. I can personally attest she is a beloved educator and highly rated amongst pediatric fellows for her education regarding childhood asthma, cough, and wheeze. We are very lucky to have her present today. We are excited to get her view on these articles and help you make a dent in your reading list. So let's get into it.
Dr. Simoneau, thank you for joining us today.
Thank you for having me. I'm excited to be with you today.
Welcome. We're excited to have you on the podcast. The article we're going to be discussing today was a systematic review published in Chest in 2016, entitled Children with Chronic Wet or Productive Cough, Treatment and Investigations. This review focused on an important and prevalent topic in pediatric pulmonology, chronic productive or wet cough. All right, to start, according to the American College of Chest Physicians, or ACCP, 2006 guidelines, chronic wet productive cough is defined as a cough greater than 4 weeks duration. Now, this differs from the adult population, where chronic cough is defined as a cough present for more than 8 weeks. And productivity is not necessarily a qualifier. So it's important to establish that in these particular studies, the age cutoff was 14 years when we talk about the pediatric literature. Dr. Simoneau, what about chronic wet productive cough in pediatric patients should we keep in mind as we discuss this paper?
Well, I think you've pointed out some of the important distinctions between adult chronic cough and pediatric chronic cough. But it's important to remember, even within pediatrics, that you also have to think about individual age groups, even more than just pediatrics as a whole. So the most common causes of cough are going to vary in different age groups. But by and large, the most common cause of cough is infectious. Kids are going to get colds. Kids are going to potentially have pneumonias. And so you want to think about those infectious etiologies first. But the other key thing that comes out of this article that we're reviewing is this idea of cough pointers. And this means that you really have to hone in on your history and physical exam to help distinguish between any potential underlying condition, because we are talking about kids. We are talking about people who may have underlying diagnoses that have not yet been identified. And so you definitely want to make sure that your history asks about those etiologies and that you're distinguishing from those who may have something underlying versus those who fall in this category of chronic wet cough, which is most concerning for protracted bacterial bronchitis. So importantly, you want to ask about, is the cough associated with feeding? What is the quality of the cough? Is it worse at one particular time of day or night? Any recent travel? And then history of recurrent sinopulmonary infections. These questions all help point you towards more specific diagnoses that then require further investigation and sort of take you out of the algorithm that this paper is addressing. Similarly, your physical exam is important. You want to make sure that you're looking for clubbing. Any clubbing would automatically sort of, again, point you in a different direction to investigate for systemic diseases like cystic fibrosis or bronchiectasis. And it's also important to remember in pediatrics that cough is never normal, and the age of onset of that cough is helpful in helping you determine your differential diagnosis. So, for example, if you have a cough that's present from birth, you're more likely to consider anatomic abnormalities as opposed to a cough that starts at age 4. And then finally, that definition of the wet cough, I think, is difficult, and it's not always as straightforward as it seems when you read it in the literature. I find that many families don't understand when I say, is the cough wet or is it productive? They think I'm talking about expectoration, and kids don't often expectorate spontaneously. So rather, I sometimes word it as, is it a junky sounding cough? Does it sound like there's mucus? And that can sometimes help you better differentiate between, is it a dry cough versus a wet cough? In this day and age, what's particularly helpful is those videos that families love to show us. So they come in with their phone and say, oh, do you want to see the cough? And, and I find that even better than the descriptors as a way to truly distinguish that we are talking about a wet cough. And then that can set you on your path through that algorithm discussed in this paper.
That is a great framework to start with, Dr. Simoneau. And for our listeners, remember, a good history goes a long way, but we now have some nice pointers for how to target that history. And I love that. Take the time to use modern technology to help you corroborate that history. So moving on, this paper looked at 2 key questions pertaining to chronic cough in pediatric populations. The first key question was, how effective are antibiotics in resolving chronic wet cough? And if so, what duration of antibiotics is required? The second key question pertains to when these patients should be referred for further investigation. In particular, this quote-unquote referral pertains to consideration of higher level of care, and in particular, CT imaging and or flexible bronchoscopy. These 2 questions kind of make sense on a temporal spectrum as well, i.e., when should I decide my standard of care approach to treatment has run its course and my pediatric patient should be referred? Any thoughts here, Dr. Simoneau?
Yeah, both are important questions. They have some good evidence referred to in this paper about in terms of how strong the evidence is. I think the first question about, how to manage the chronic cough, again, once you've looked for those cough pointers and you've decided this is a wet cough that's gone on beyond 4 weeks, then you're really less likely to be talking about a post-viral or prolonged upper respiratory tract illness. And at that point, it is worth a trial of antibiotic treatment. And the data in this paper seems to support that. In particular, in children, though, you don't want to miss any of those like chronic underlying conditions. So again, you really want to make sure you're talking about the population that's being addressed by these studies. And it's important to sort of think about those underlying etiologies that may benefit from early identification and treatment versus this is, a sort of individual instance of cough that's gone on that will be treated with antibiotics. But when, some of the studies that have looked at that post-viral cough that persists, most kids with a cold have a cough for about 7 to 10 days. And in one study by O'Grady et al., 75% of kids had resolution of cough within 7 days. But 20% of those kids coughed beyond 28 days. And those are the kids we're talking about in this paper. And of those who continued to cough, 30% of them did end up having an underlying condition. So distinguishing again early on between those with that underlying condition versus those who just need a course of antibiotics for protracted bacterial bronchitis, I think is really one of the keys that comes out of the evidence discussed in this paper.
Dr. Simoneau, you just made a lot of distinguishes between antibiotics for protracted bacterial bronchitis and additional underlying conditions. Why should we worry about the additional conditions? My understanding specifically is that bronchiectasis in pediatric patients is important to identify early because early diagnosis and targeted treatment can result in less airway damage. Is there anything else that you'd like to emphasize here?
Yeah, I think you're exactly right that, what we've learned about bronchiectasis over time is that it's not a fixed pattern or pathology that can't be reversed at all. And so treatment, can lead to improvement both in lung function and of arresting the progression. So that identification of the sort of underlying etiologies is important. But the data, suggested here is that upwards of 75 to 80% of kids who have this wet cough past 4 weeks will have resolution of their symptoms with some 2 to 4 week course of antibiotics. So it's important to sort of keep this idea of chronic wet cough in your differential, as long as you again rule out the sort of more serious systemic underlying diseases and try to differentiate this cough started 4 weeks ago. Before that, this child had no other underlying pathology or difficulty versus this wet cough that's been there for several months. They've had a history of recurrent pneumonias, or they have chronic aspiration, or they have some reason to have underlying bronchiectasis that really differentiates your investigation. In the chest expert panel recommendations, the ACCP guidelines that you mentioned before, studies have looked at the outcomes of children who had this acute cough that then persisted beyond 4 weeks. They did find upwards of 30% of those kids had an underlying new or serious chronic lung condition. So again, you can use your trial of antibiotics, but then if the cough does not respond and completely resolve, then you have to go on to still consider other etiologies. And as you mentioned, many of these things are treatable. So if you're thinking about like young kids who have oropharyngeal dysphagia and aspiration, if you recognize that early on and treat that with either thickened feeds or decreasing oral feeds, then they may be less likely to develop recurrent pneumonia, less likely to go on to develop complications such as bronchiectasis. So again, when we're sort of thinking about our pediatric population, we just have to keep in mind that, we can really drastically change their outcomes if we have an early diagnosis and treatment.
Excellent. And obviously, with how young these patients are, those long-term outcomes are going to really come into play. As one who typically cares for adult pulmonary patients, I'm going to try to make a quick parallel here. We've now emphasized a good number of important points about how this study in particular fills an area of significant need to potentially prevent future morbidity in these patients. But this may be underestimated if not studied in a true longitudinal fashion. Is chronic cough in the pediatric population as detrimental to quality of life as it is in, say, the adult population?
Yeah, I would say definitely as detrimental and possibly more so because this cough is impacting a child, but also their family. And so it has the potential to impact missed work as well as missed school days. And so several of the studies mentioned or reviewed in this paper do show decreased quality of life scores that affect the child's sleep, the ability to play, their school performance, and also can contribute to some level of anxiety for the parents. Particularly now, I would say in these post-COVID times, everybody's alarmed about a cough and, kids cough once and they can't go to school and then they need another swab in their nose. All of this is can be quite distressing. In some of my adolescent patients, I've seen this really have an impact on their mental health when they've had a consistent cough for 4 weeks. People look at them funny. It doesn't, people don't feel good about how they're treated with a cough. And then the other thing that you've mentioned is missed school days. And so we know from kids with asthma that they do miss more school days than those without. And this in turn can have a long-term impact on their educational achievement. And so I think those missed school days that then result in missed work days and then potential financial implications for the family, all of that really adds up to being quite distressing. Anecdotally, what's interesting, what I think I hear most from families that's the most distressing factor with cough is loss of sleep. And so when kids are coughing at night, parents aren't sleeping. And I think as we all know, that lack of sleep really has a significant impact on everything else from there.
Great, thank you. Really good points to consider. Throughout our conversation, you've been great at alluding to already helping us dive into some of the data that's been presented in the article, specifically referring to key question number 1. We've talked about the use of antibiotics, but now let's talk about duration. And when we're considering antibiotics for chronic wet cough, what duration is required? There was a healthy spread of systematic reviews, randomized controlled trials, and other prospective and retrospective studies included in this review. Dr. Simoneau, what should we keep in mind about such heterogeneous data?
Yeah, I think you make a really important point, Kristen, that when you do see this sort of heterogeneity to the data, you really do, I get a little bit suspicious that maybe we don't actually know the answer. And so one of the challenges that these studies are faced with is really defining the population that they're studying. And I think we can see from the collection of studies in this article that there's quite a range, particularly when you talk about the age range. So some of the studies, for example, included everyone under 18 years of age, but some focused on those who were 6 to 14 years of age. And then some we just looked at kids under 6. And so again, you're going to have a set of differential diagnoses, for each of those age ranges, and the probability of different diagnoses differs based on the ages. Similarly, as you talked about, that duration of cough varied between the studies. And so while we have defined chronic cough as cough that goes beyond 4 weeks, some of the studies included actually only required that someone had a cough for 10 days or more. This probably plays less of a role in the heterogeneity of the data because the median length of cough in those studies was at least 3 weeks. So, we are still talking about a cough that has gone on for, 3 to 4 weeks. And when you talk about duration of antibiotic treatment, there was some variability. And, because there's a lack of randomized controlled trials, particularly in pediatrics, it makes it challenging. I would say relative to other studies, this one actually has a good representation of randomized controlled trials. And so, there's one study that compared 7 days of antibiotics versus no antibiotics. And the 7 days of antibiotics was actually pretty effective. But in general, it seems that the data suggests that you need about 2 weeks of antibiotics, at least for starters, and sometimes up to 4 weeks of antibiotics.
That was a great question, Kristen. And thank you, Dr. Simoneau, for outlining all of that. These are important points to consider, right? The data being compiled here represents significant gaps in the current literature, and it sort of paves the way forward. But we have to utilize studies like this in order to treat our patients on a day-to-day basis. But we have to keep in mind things such as age discrepancies, and this is what we have for now when reconciling such heterogeneous data, right? From what I gathered, there wasn't really a gold standard established for the diagnosis of chronic wet cough in the patients that were included in these studies. Some of the studies only included such patients as a subset, and others went so far as to establish a diagnosis of protracted bacterial bronchitis, or PBB, via bronchoscopy. What clinical or other criteria do you think we can take away from these data when establishing a diagnosis of chronic wet cough other than the previously mentioned wet cough for greater than or equal to 4 weeks duration?
Yeah, so I think that, again, I'm going to sound like a broken record on this podcast, but I think, again, it comes down to that defining your population. You have to make sure that you've at least thought about and not necessarily ruled out, but seem less convinced that there's an underlying systemic disorder causing this cough. And this is where I think some of the cough algorithms can be helpful. And so, if you look at the CHEST, the ACCP guidelines, they have a nice cough algorithm that sort of walks you through once you have decided that there are none of these cough pointers and you're really just left with a wet cough and it's gone on for 4 weeks. Then you do a trial of antibiotics. And if that trial of antibiotics works, great. But if that trial of antibiotics doesn't work, then you may at that point need further investigation. And I think that's a really appropriate approach and I think the data supports that, because not everybody with a cough for 4 weeks needs a bronchoscopy. And in kids where we're going to have to put them under anesthesia and there's some risk associated with anesthesia, we do want to be cautious with not overly utilizing bronchoscopy. So this data suggests that there's good response to that approach with 2 weeks of antibiotic, and it's a good proportion of kids who don't have anything else underlying and would benefit from that approach. But again, you do have to think about the age of the child, the severity of the symptoms, your entire history, and your physical. And if you're thinking about a otherwise healthy 6-year-old who has a cough since having a upper respiratory infection and it's only 10 days later, you can probably let them continue to cough and not do a bronchoscopy and not treat with antibiotics. And then at 4 weeks, you trial the antibiotics. But if it's a 2-month-old who's had a wet cough for a month and it's associated with drinking, then you really need to come out of the algorithm and assess for dysphagia and aspiration. And so again, I think those cough pointers and then following the algorithm could be really helpful.
Thank you. And when talking about a trial of antibiotics, antibiotic choice was a key component that the authors evaluated. And for good reason, amoxicillin clavulanate, or Augmentin, was the top choice, given that the three most common organisms were Haemophilus influenza, Streptococcus pneumonia, and Moraxella catarrhalis. But at this point, I'd always make the pitch to also check local antibiogram for consideration of antibiotic choice. Dr. Simoneau, were there any key populations that were excluded or otherwise need to be considered in regards to key question number 1?
Yes, absolutely. And I think that's an important thing to consider. And it speaks to why the data presented here is so helpful, because there were several studies that looked at BAL data, and it was pretty consistent in terms of which bacteria grew. And so those three, most common pediatric sinopulmonary organisms, came out from the bronchoscopy data. But importantly, kids who have underlying systemic diseases such as cystic fibrosis were excluded. Those who have known bronchiectasis were excluded. The bacteria that grow in your BAL is going to likely be different for those individuals. And so anyone known to have an underlying disease were excluded from most of these papers. But then, like I said, the BAL data was pretty consistent. And so Augmentin is probably a good choice as a starting agent. In some cases, you may be okay with high dose amoxicillin, depending on your local strep pneumo resistance patterns. But again, key to make sure that you're talking about, a population fits this chronic cough algorithm and doesn't have risk factors for other underlying diseases.
All right. So to summarize, for key question number 1, it seems to me that based on these heterogeneous yet quite robust data, that antibiotics, and in particular our tried and true amoxicillin clavulanate, do improve resolution of chronic wet cough in pediatric patients under the age of 14. The duration required for optimal risk versus benefit is potentially around 4 weeks, with a number needed to treat estimated around 3 patients. But Dr. Simoneau, before we move on, anything to add here? Please put me in my place.
No, I think that's right. I think the only thing to be cautious about is just that starting with 4 weeks of antibiotics. I think again, the papers had some variability in duration of treatment. And I find, what I typically do and what is in that chest expert panel article is to start with 2 weeks. And then if there's some improvement, but you're not fully resolved with your cough at the end of 2 weeks, then I'll do an additional 2 weeks to get to the 4 weeks of antibiotics. If there's no improvement after 2 weeks, then you're probably not treating the right thing. And then it's probably worth moving on to other investigation. And that sort of moves us into that second key question that was asked.
Excellent. Well, in that light, let's move on to key question 2. Here, the authors sought to answer the essential question of when to refer. The authors included 17 total studies, one being a randomized controlled trial, the remainder being prospective and retrospective studies. It is also important to mention that this randomized controlled trial was not a true evaluation of treatment for chronic wet cough, but instead it utilized an algorithm strategy. For the most part, though, it appears children with chronic wet cough were well represented, with the exception of 3 prospective studies. What really struck me was the table labeled Table 7 on page 139. And I'd like to point this out to the listeners. I feel like this is a hugely high yield table. The table offers a nice go-to reference when seeing patients in clinic or in the hospital in regard to pointers that was previously alluded to.
Yeah, I think you've hit the nail on the head. And, clearly I'm going to keep coming back to that, but that thorough history is key. And that table, really points you to some of the things that you need to ask about or address. And so, as you've mentioned, some of the things on that list are fairly obvious. For example, a patient with hemoptysis, hopefully you're going to go down a different path and you have a different differential and you've sort of come out of the PBB pathway. And so I guess if I were to hone down that table to some of the key things that are often overlooked and maybe a little bit harder to tease apart. So one is the association with feeding. So particularly in younger children, I spend a lot of time in the aerodigestive clinic and the fellows make fun of me for always asking about, is the kid aspirating or, is there any association of symptoms with feeding? But I think that that's really important, particularly in those kids under 1, where the most common causes of cough are reflux, dysphagia, and aspiration. Second is that physical exam finding of clubbing, which should immediately point you towards a workup for cystic fibrosis and bronchiectasis. And then third is failure to thrive or even suboptimal growth, which when you put that together with wet cough, then you really should be sort of raising alarm for more systemic diseases, so such as immune deficiency or cystic fibrosis. So that table is really helpful, but again, I think that there are some things in that table that are more obvious than others, and making sure that you're covering all of them is probably important.
Those fellows might not admit it now, but know that they'll eventually realize you're right. All right. Should we take a moment to discuss how the ACCP guidelines and British Thoracic Society guidelines factored in here? Some of the studies sought to sort of validate or even invalidate such guidelines, but tell our audience, Dr. Simoneau, how do you think these data actually hold up to the guidelines or vice versa?
The data by and large supports the current guidelines. And again, importantly, if there are cough pointers or that concern for systemic disease or any findings in addition to the wet cough, then earlier referral is appropriate. The British Thoracic Guidelines suggest treating with antibiotics for 4 to 6 weeks before referral. And I think that given this data, that's a little bit long. In particular, there's one of the studies in this paper showed that wet cough that doesn't resolve in 4 weeks is associated with a higher risk of bronchiectasis. And so I think a shorter test of antibiotics probably makes sense. But the CHEST guidelines are well aligned with this data. And again, advocating for the evaluation of the cough pointers and then referral if the cough doesn't improve after 4 weeks of antibiotics.
And then a question that I must ask, Dr. Simoneau, what should we mention about the prevalence of bronchiectasis, tracheomalacia, or bronchomalacia in some of these studies? Is this the needle in the haystack we're looking for or referring for? In our pediatric patients, should we have a particular threshold for CT imaging? Specifically, do we do it before referral or allow the next referring physician to make that decision?
Yeah, so I think that bronchiectasis, tracheomalacia, and bronchomalacia, those are really the things that we're potentially just putting a Band-Aid on with our antibiotic approach here. But if you don't hear stridor or wheezing on exam, I think tracheomalacia and bronchomalacia are less likely. And so it's possible that those patients weren't included in these studies because of they, again, got pointed in a different direction. And then the key with bronchiectasis is that if it's a kid who has bronchiectasis that you don't know about yet, you might treat with antibiotics and they'll improve, but then their cough is going to come back and it's going to continue. They'll continue to have a wet cough. And so you'll still get to further evaluation and, sort of finding those kids with bronchiectasis after that trial of antibiotic. And I think when you're referring to a specialist, I think it's best to let the specialist decide about what the next step is going to be. In young kids, a chest CT often requires sedation or anesthesia. Then there's also concern about radiation. And then there's also different protocols used for chest CT. So I think these things are best discussed with the family by a specialist. So I would probably, once you've done the antibiotic trial, maybe a chest x-ray at that point, I think it's reasonable to let the specialist decide the workup from there and try to differentiate. Should we do a bronchoscopy first or the chest CT?
Awesome. I really like that sort of deterministic or less is more approach on the way to referral, just keeping in mind over testing, excess testing, and allowing the specialist, if you are referring, to really take the reins from there. Okay, you alluded to this earlier, Dr. Simoneau, but did you have any additional thoughts about how our listeners should be thinking about other important inherited conditions such as CF or more particularly immunodeficiencies or related conditions?
Yeah, I think, again, it sort of speaks to that importance of your history. The family history plays a role here. You want to make sure that you've asked about family history of cystic fibrosis and immune deficiencies. Any kids who have other need for recurrent antibiotics, if they're having skin infections or sinus and ear infections, sort of anything beyond just this isolated wet cough, I think you do want to think about referral sooner. Similarly, you want to ask about the history of asthma. We often think of asthma as a dry cough, which it typically is, but in the setting of exacerbation can also be a wet cough. And so again, that family history and history of other symptoms, I think can really, help to point you in the right direction so that we're not overusing antibiotics and we're not letting too many kids keep coughing for 4 weeks at a time.
And with this study in mind, Dr. Simoneau, as the referral specialist, how do you approach families with the conversation about the indication for bronchoscopy or other procedures that are potentially needed under anesthesia?
Yeah, I think the benefit we have of seeing kids after 4 weeks of coughing is the families really want the cough gone. And so they typically are more interested in getting to the bottom of the cause of the cough. And so that's where I think you can really sell bronchoscopy. No one wants to put their kid under anesthesia or go through a procedure. But if it's going to give us information that can really direct our therapy and help identify an underlying cause, then it's worth doing. So again, I sort of go back to that history and, if there's been weight loss or poor weight gain, or if there's a travel history that suggests maybe exposure to tuberculosis or non-tubercular mycobacteria, sort of those are things that we might be able to identify on bronchoscopy. Again, any like asymmetric exam findings, you would want to pursue bronchoscopy sooner rather than later. Again, other than those cough pointers, otherwise healthy kid who's coughed for 4 weeks, I do think that the antibiotics first before bronchoscopy is the way to go. And then if they're still coughing at that point, then you need to march down the pathway of evaluation.
This was a very humbling episode for me. And I think I am going to be able to take away some of these pointers for my adult population. So thank you guys for keeping all of this relevant to me as well. Dr. Simoneau, any final thoughts about this quite robust systematic review and meta-analysis?
Yeah, I think this is a great paper to review. And I think, it also just highlights the importance of understanding the data. And, again, you have to know that you're applying the data to the right population. And so, make sure you've taken that complete history and that you're really just in the chronic cough pathway. But then I think there's some good evidence for, use of antibiotics in that regard.
Well, thank you, Dr. Simoneau, for joining us for this episode.
Thanks so much for having me. It's been a pleasure.
Thank you for joining us today. For more, visit our website at thoracic.org. Find more podcasts from the ATS Professional Development Committee on YouTube. Don't forget to like, comment, and subscribe so you never miss a show.